Good afternoon, everybody, and welcome to our webinar called Trauma Informed Care Through the Lens of COVID. My name is Mary McCarty Arias. I'll be your trainer for the day. So thank you very much for coming. I think some of you I talked to yesterday when I did the training, and you didn't have to be here yesterday, but glad that people are here. So just a couple of things before I go on in terms of housekeeping. If you've heard this commercial many times, you can probably ignore it, but I just did want to add a couple of things. I represent or I work for the Northeast and Caribbean ATTC, the Addiction Technology and Transfer Center, and we are located in New York. We're at New York Presbyterian. We're at the New York State Psychiatric Institute on 168th Street on the west side. As many of you may have also experienced, I have not been in my office in probably 6 or 7 months, but that's where we're located. A couple of things. The ATTC, or our ATTC, covers all of New Jersey, all of New York State, the Virgin Islands, and Puerto Rico. And I think the good thing about the webinars is we've had people from all over the country. So welcome, depending on whichever time zone you're in. I'm glad that you are here. The reason I was sharing about the Northeast and Caribbean ATTC is because I'm going to throw this out there. If you are in those states that I just mentioned, we can do a specific, we call them agency specific trainings for your place for free. These days we're doing everything on Zoom. So at the end, you'll be able to see my email. And if you think it's something you'll want to do, please let me know. We like to have at least 20 to 25 people, and we can do some of the courses that we do here for a smaller number of people at your site. Like, for example, somebody was yesterday asking me if I'm going to do the ethics course again. And I may in a couple of months, but this way, if you need the ethics hours, please let me know. And thanks, everybody. I know that as we start, often people are writing in their names and where you're from. So far, it looks like we have people from New York. We have people from Wisconsin. And so welcome to all. So if you feel like writing your name in, that's pretty cool and not mandatory. We'll just get an idea of where people are from. Excuse me. Another thing that I'm going to be doing in December is I am going to be doing, there's going to be 3 webinars in a row. Actually, they're going to be on Wednesdays, and they come from the ATTC stimulant package, which is a fancy term for, they are going to be about actually, they're going to be about cocaine and methamphetamine. So if you're interested, there will be 3 sessions. You don't have to go to all 3, but you're most welcome to do that. So cool. So we have people from all over today, and as well as some of my friends in New York and New Jersey. So glad that, again, that you are here. I think, again, the cool thing is that if you go to that national ATTC site, you can see whichever webinars are offered about the country. And the good thing about webinars is we can take up to 1,000 people, so you don't get closed out. Anyway, that's the commercial, and let me move on. So this is required in every one of our trainings, and it's just a disclaimer, and the key is that the development of these training materials, which we're going over today, was supported by a grant. There's a grant number. M. Chappell is Mike Chappell. He is the director of the Northeast and Caribbean ATTC. And the key with this, by the way, is that this information comes from our work. It's from us. It's not necessarily from SAMHSA. SAMHSA stands for Substance Abuse and Mental Health Services Administration, and it is a federal agency which actually supports all the ATTCs as well as other places. And we're glad that, again, I'm just looking actually, we have people from Ireland. Thank you. We have people from Canada. So we are all getting all over the world. Welcome. So this also is required in all of our courses, but I think it's important in terms of the values that we like to affirm from the ATTC, as well as our own Northeast and Caribbean ATTC. And it's, as you can see up there, we know that words have power, and we really want to support people first. So it's the person with a disability, as opposed to just looking at the disability itself. And so we like to try to use affirming language to promote the promises of recovery by advancing evidence-based and culturally informed practices. So we'll do our best on that. And one thing I've said to people, at least when I was teaching at NYU, as you start to look at people first, it will help you really to look at them as people first, not just people who are coming to you with big problems. So that is something for that. There is my picture. And just, I've been in the field for many years and started as a vocational rehabilitation counselor in drug treatment, and also worked with people with co-occurring disorders, probably before it was called co-occurring disorders. If somebody just said, is this on webinar on trauma? It's on trauma-informed care. It will include something on trauma, and I'll go over the goals and objectives. So hold on to that, and I'll let you know what we're going to do. The reason we started doing courses on trauma is for many years we had a contract with the AIDS Institute, and we started doing work with them on co-occurring disorders, and the course on trauma really resulted from looking at co-occurring disorders. And when we talk about the DSM-5 later on, the Diagnostic and Statistical Manual of Mental Disorders, when the DSM-5 came out, it was the first time they had like their own chapter on trauma. And that was a change and probably a necessary one. You know, we used to do a lot of in-person trainings in upstate New York, by the way, because I see people from Utica, Binghamton. I look forward to when that might happen, but I have no idea when that might happen. Same thing with New Jersey, too. So, sorry, they won't send me to California or to Ireland to train, but I would go if I could. Anyway, so the goals of this course are to understand the scope, definition, and impact of trauma on their clients. So we'll look at some of the statistics, although probably sometimes when you go to a course, it's really educating your instincts that some of this information you probably already know, but we'll put some numbers to it, or we'll put hopefully some more information to it. When we redid this course, by the way, and looked at it under the lens of COVID-19, because that really has kind of changed how we've done things. I don't know where people, I mean, I can see where you are all over the world, and actually most people who are in the United States are dealing with, still with social distancing. And actually for the person who's from Ireland, my understanding is that the same thing too. So I wanted to throw that in there as well. Now, the objectives, we'll talk about what is trauma, and we'll look at some epidemiology, and which is a fancy term for statistics. We'll actually define the term pandemic. I have to say that I've been in the field for a while, and we talked sometimes about epidemics, we talked about syndemics. I did not talk about pandemic until this year, and then we'll compare. So we'll look at, for example, the Spanish flu. We'll also look at 9/11 in New York, which is not a pandemic, but it was a trauma. So we'll look at some of that. The good news about trauma, by the way, is that when people have the right interventions, that you can recover from it. It doesn't mean, by the way, that it goes away, but people can integrate their traumas and live very productive lives. So we'll also look at resiliency and risk factors for trauma. I think one of the reasons I like presenting resiliency factors probably first is because many of you are actually helping people with resiliency factors. You can also look and apply this to yourself, by the way, because resiliency is kind of an interesting word these days. You know, resiliency sometimes means like to bounce back. And I was at a webinar, and the advantage of being actually at the New York State Psychiatric Institute is they have webinars pretty regularly for us to go to. And what one of the professors was saying was that, you know, we feel like we have to like bounce back really fast. Like if today is Wednesday, we have to be better by tomorrow. However, with this pandemic and all the stuff that's gone on with that, resiliency has its own time. So it's just something to keep in mind, and we'll talk about that. And then finally, we will get to talk about what is trauma-informed care, and we'll look at some of the principles of trauma-informed care. All right, ready? So here's where I'm going to ask you to please write in. This could be a ballpark figure, by the way. Also, I think there's a lot of people, so sometimes the chat goes pretty quickly, and I can't read everything. If somebody wrote in the new normal is abnormal, please comment. Here's what I'm going to say about that. And thanks as people are writing in. There's an expression that says that abnormal, let's see, let me remember it word for word, but abnormal reactions to abnormal events are normal. Let me say it again. Abnormal reactions to abnormal events are normal. So that's something to keep in mind. All right, so I'm seeing the numbers. Thanks, everybody. So I see 100%, almost all, nearly all, 80%. Yeah, and you all can read these, by the way, so you can see. Somebody said 70%, all of them, guessing 90%. We're talking about a lot of people, right? The key, by the way, is, and I didn't break it down into, you know, who experiences what kind of trauma, although you can really get that, by the way, about women, men, LGBT people, and something to keep in mind that we learned from the Center for Trauma-Informed Care is that assume that 99% of people who come to you have experienced trauma. Please assume, I know we're not supposed to assume, but that 99% of the people who come into your office or wherever you are have experienced trauma. Now, I haven't met that 1%, but the key is that we've all experienced trauma, and that's all of us. So clients and us as well. So I can see, again, you can look at all the numbers that you see. So thank you for writing that in. So here's the working definition of what is trauma. I don't know if anybody's read any of the TIPS books, the treatment improvement protocol. I might actually type that in to the, I'm going to type it in. Typed it into the chat because you can get free books from SAMHSA, and tip 57 is on trauma-informed care. So for those of you who want a free book, all you really have to do is Google that, and you can download it. They used to send all this stuff out free, and some of the tips they still do. I don't know if this one is back in print, but it's really, really, really good. So when you look at, and I took this from their definition, and again, there's probably many different kinds of definitions, but here's what they look at, and they talk about the 3 E's. So the first E stands for events, event or events. So for example, for some people, it can be one event, it could be a series of events. So it might be sexual assault as one event, it might be sexual abuse, childhood sexual abuse, where there's many events. And then it's also important, it's the individual's experience of it. So the second E is for experience. So you could have two people and they may experience the same trauma or the same event, but one person may feel traumatized by the event, the experience, and the other might. So it's one of those really, it depends. And some of you have heard who know me. One of my favorite trainer answers is, it depends. So it really is the individual's experience, and they determine, by the way, whether it was traumatic or not you. And the other piece is the long-lasting adverse effects. So what happens long-lasting? And it's interesting because, as we go through this, I'm going to say what some of the research is saying from Columbia, that the long-lasting effects, that 2/3 of people will get better and 1/3 may still deal with some of the mental health issues around that. Okay, I'm just going to the chat. Barbara wrote, as agents of change, it's important that we all discuss stages of change, which is different. Yep. We as professionals know where to find the help for our constituents. We have to remain resourceful, and of course these trainings help us. Thank you, and I agree with that. I'm doing a course next week on overview of harm reduction for the PTTC, the Prevention Technology and Transfer Center, and we'll get into stages of change, but many of you have gotten into that from other courses. So to kind of take it back, this is a working definition, and I always say, when I'm in person, you could agree with me or not, but these are some of the things to keep in mind. And I think one of the keys, by the way, is everyone is different, and the person determines whether it was traumatic or not for them. So here's a list of traumas. Again, this comes from Tip 57, and they broke it down into natural causes, accidents, and intentional acts. So as you look at that, by the way, you can see on the left-hand side the variety of natural causes. Certainly, we've gone through a number of them. And actually, COVID-19 doesn't necessarily fit into natural causes, although I suppose it could. But many people actually throughout the country, through the United States, again, some of you are from other countries, but have been dealing with hurricanes, and fires, for those of you in California. So those are all natural causes. Accidents, you could take a look, see what you see. It's interesting too. It's interesting, the reaction, because I see accidental gun shooting there and I think, ooh, that one would be a tough one to deal with. And then I think for many of our clients, they're dealing with a lot of the intentional acts. So you can see there the variety. I would add, by the way, I think I tried to add into the box one day about discrimination, but you could see terrorism, arson, homicide, and suicide for many of our clients, domestic violence, bullying for many of our clients, genocide, physical abuse or neglect, sexual assault, warfare. So those are just some, by the way. You could put in there food insecurity, and you could probably make a whole list of the intentional ones. So actually, before I get to the pieces on COVID, which of these do you think? Yeah, thanks, Michael. Yeah, gun violence, racism, definitely. And that could be in the whole piece, oppression and systemic racism. We'll talk about that too with actually resiliency factors and risk factors. Yeah, so all those things that you're writing in, thanks, Doug, for food insecurity, those are all things that many people are dealing with today. And in a sense, even we're more aware of them. And food insecurity is a big thing as people are losing their jobs. And actually losing a job, I know as a rehab counselor, for many people, that is traumatic as well. So here's a question. Which do you think is easier to heal, natural, accidents, or intentional? Which do you think is easier to heal, natural, accidents, or intentional? Oh, yes. Thank you, Michael McCarthy, about, yes, SARS or COVID. That one's a tricky one, right? got COVID, opiate epidemic on top of others. Absolutely. Yeah, lots of people are writing natural. Some people are writing accidental. A couple of you are writing it depends. I'm going to say, and this is a generalization, by the way, is that for some people, natural causes may, by the way, have an easier way to heal. And the reason is that sometimes when something happens, like let's say an earthquake, that it's happened to a lot of people. And so that sometimes people are supporting each other. And also maybe people are trying to help other people, whereas you may not see that for some of the others. But I can't quantify that, by the way, but that's some of what the literature said. So you actually, no one has to agree with me on that one. And so Anthony, you say you don't think it was natural because it was started by humans. Are you all talking about, if you're talking about COVID-19, that'll be an interesting thing. I always have to be careful with politics, by the way, because I've gotten into trouble for this in the past. Let's see what people are writing. Natural causes. Some have speculated germ warfare from outer space. COVID is natural. I'm going to say let's hold on to that one. But there are things that I really wanted to put in about pandemics. So, as I said before, I never used the word pandemic all that much. And so here's some definitions. It comes from WHO, the World Health Organization. So they kind of define it as worldwide spread of a new disease. I think that's pretty simple. The Center for Disease Control, the CDC, said it spreads around the world and most people will not have immunity. And these definitions, by the way, came out in 2020. So as you know, they all have really good websites. And so it's just something to kind of look at. We're not going to have a test on this, by the way, so you don't have to know this, but just to put it out there, it is worldwide. Now, everybody always kind of looks at the Spanish flu, right? And first of all, I'm going to start with the name. In Spain, by the way, they didn't call it the Spanish flu. In Germany, they called it the Spanish flu. In Spain, they called it probably another country's name. So it's referred to as the Spanish flu. And what we know is that it killed 50 million people worldwide. 500,000 Americans died. So talking about, again, big numbers. For those of you and those of us who are counselors and or in the mental health field, the number of psychiatric hospitalizations increased by 7.2% in the following 2 years. That's pretty not surprising, right? And what did survivors report? Sleep disturbances, depression, mental distraction, dizziness, and difficulties coping. And another thing to throw in there is that it also coincided with World War I. And when people came back from the war, a lot of the rehabilitation programs actually started after World War I. Why? Because people were coming back and they were injured. So I read a book too about methamphetamines in Germany, and in the 1920s, actually in Germany they had a high level of use of stimulant drugs. Why? Because they said that people were depressed and after losing the war. So who knows what'll happen when we see what maybe the trends will be. And maybe the good news is that after the Spanish flu in the 1920s in the United States, we had the roaring 20s and people returned to, quote, normal, however you define that. So Spanish flu is often referred to as we talk about, you know, what's going on in the world today. Now, I put in 9/11. Now, 9/11 for New Yorkers was big, but actually for people all over the country. So it was more of an event, obviously, than a pandemic. But here's what they saw. And if you look at why that statistic at the bottom is 2003, because this came out actually after after 9/11. And what did we see? An increase in alcohol, increase in tobacco use and marijuana. We're actually seeing a lot of the same thing today, only I think the numbers are bigger, and an increase in anger, stress, and sadness. When I was working in treatment, a lot of people in recovery relapsed after that. And at the time, my husband was working for an EAP, and an employee assistance program, and they were doing a lot of work with firefighters who had been in recovery and relapsed. So that was a big thing. Oh, you know what? I know people are writing in, by the way, about germ warfare and COVID. So I'm going to say you can write that in. I'm pausing because I think I need to stay away from that, of whether it was a man-made illness or a natural disease. There's a whole political piece on that I really can't, I don't think it would be helpful to get into. I am looking at what you're writing though. I mean, viruses are natural, by the way, and a virus's job is to replicate. And so something to keep in mind. So you can see what people are writing in. And I think you're still talking about COVID, right? So actually, this is the slide on COVID, but this is what makes it different, you know, regardless of how it started, by the way. But it's really the magnitude. I mean, for many of you, actually for most of us, I don't know if anybody was alive in 1918 with the Spanish flu, although some of your grandparents or great-grandparents might have been, but just the magnitude of it has been really gigantic. There's a certain lack of control or powerlessness. We don't know when it's going to end. We don't know whether we can go back to work. And we don't know, again, when it's going to end. I will say that for me personally, when I heard that the vaccines were coming out, it made me happier. But for many of you, you know that for many of you that it was, oh, sorry, when I read some of the chats, I kind of lose what I'm saying. But anyway, not knowing the outcome, increase in stress and anxiety as a normal response. And that kind of goes to what somebody said before. This is a normal response to something. It exacerbates any pre-existing problems. So for many of you who are working with people with other mental illnesses or other illnesses, it can make them worse. And most people are dealing with losses. Now, some of you are have dealt with personal losses of clients. Some families have dealt with a lot of people. And I am going to go to the chat. So Michael, thank you. I'm a psychologist and an epidemiologist. It was not man-made. I'm going to stick to that one for today, okay? Thank you. So the key is that we are dealing with it, and it's something that we haven't been used to. All right, this goes to the acute trauma versus post-traumatic stress. And as I was saying before, the DSM-5, the Diagnostic and Statistical Manual of Mental Disorders, has a new chapter in trauma that was new before the other DSMs. And by the way, not everybody gets a diagnosis. So it's not necessary to get a diagnosis. Many people, by the way, have resiliency factors and will get through this without having a diagnosis, but some people might. And just the key, by the way, I think here is acute is really, it really has to do with time. So it's really after the event, up to usually to 30 days. And then for some people, and for many of the people in our field, they may be dealing with post-traumatic stress. So it's, again, occurs after the event and the experience of symptoms become pervasive. If you were to go to the DSM-5 and kind of look at that, many of your clients or people experience flashbacks. And the thing with flashbacks is that they are a person's re-experiencing the event without any distance. And so that can be very scary to a lot of people. What they did, by the way, in the DSM-5 is they changed, you didn't have to have extreme fear to get a diagnosis. And the reason they did that was because firefighters, first responders, they are used to kind of going into fires or going into buildings that are on fire or other things. And they're not always, it doesn't mean they're not experiencing fear, but that's usually not the first thing that they're thinking about. Yeah, Sakina said, I imagine that some of us are being COVID triggered as we participate in this webinar. Actually, thanks for saying that, because probably what I could have said at the beginning of the webinar, whenever you go to a training, by the way, especially on trauma, because many of us have experienced traumas, you might get triggered anyway. And depending on what's going on with you around COVID. So yes, I always tell people, take care of yourself, do what you need to do. Some people need to call sponsors. Some of you know that I always proselytize on self-care, and that self-care is not being selfish. It's really important to take care of yourself. So thank you again. Thanks, Sakina, for bringing that up. Now, many of our clients, by the way, have experienced complex trauma. And what that means is that clients have sometimes experienced multiple traumas. And what often does happen is they're not integrated. So for example, somebody may have experienced food insecurity as a child, and then they go to college, and they are victims of domestic violence, and then they have like a whole series of things. And the importance of that is that you don't develop an immunity to trauma. It's like sometimes it may make you stronger, by the way, but you don't develop an immunity to it. So if that person has had many traumas and they haven't had help with them, sometimes something simple will happen when they're with you, and you'll wonder kind of what that is. So the idea is we want to have traumas that we can integrate, or else the person will suffer. Yeah, Michael, I agree with you. The sad reality is that for people of color, they are definitely overrepresented in COVID cases. Absolutely. Yes, and thanks, Marcia. Sometimes we are able to integrate our experiences without developing trauma. Yes, and that kind of goes back to, it depends, that some people can integrate, and it depends on, I think actually the next slide will be on resiliency factors. So that's going to be my segue to, oh wait, sorry, I have risk factors there first. Actually, let me go to resiliency first, and then I'll go back. So resiliency is really protective factors. And you can, by the way, the purpose of the training is not necessarily to you to assess your own resiliency, but I do that when I'm studying, by the way. So you look at, for example, social supports, family supports. So then the more support people have, the more resiliency they have. Ideal world, by the way, people would have economic stability. We know that doesn't happen. Employment. So all the rehab counselors out there, we talk about when you have a job or work that you love, it is a protective factor. Some of you help people with all of these things, with developing optimism and healthy self-esteem, and not like fake self-esteem or fake optimism, but some of the things that you help people. Oh yes, somebody said social support as long as it's 6 feet apart and only those in your family circle. Well, I wrote down on a Post-it, by the way, about the difference between, we keep talking social distancing, right? But social distancing versus physical distancing. What that means is that you should stay away from people for 6 feet, but it doesn't mean you can't call up people or be on Zoom conferences or figure out ways to connect or go for walks when it's really, when you're outdoors. So that is, yes, that is something. And actually kind of messed up for a lot of us. A lot of the things that we used to do that made us feel good, you can't do anymore. or you have to figure out, actually, if you have resiliency, you figure out other ways to do them. Some of you help people find meaning in life. You help with aptitude, adaptability, spirituality. So it may not be necessarily religion, but I know that as some of you have programs where you connect people to spirituality, that's an important part of resiliency factors. So curiosity and openness to experience. So the key of the resiliency factors is the more that you have, or the more you help people have, the easier it may be, again, I'm saying maybe, to develop, to have less responses to the trauma. I'm going to go backwards to some of the factors, and some of you have mentioned these, by the way, in the chat. So here's what we know. So what are some of the risk factors? So traumatic experiences experienced in the past. Many of you are familiar with that whole list of them. What's the nature and intensity of them? And again, some of them are long periods of time, some of them are short. How many stressors did they experience? I already said the length of exposure. Poverty is another one, by the way. And so I think it's important to kind of look at that. And as people were talking about, whenever we talk about access to care, which sounds like a saying we throw out all the time, but actually poverty decreases or increases the ability, or actually it decreases the ability to have access to care. So if you're worrying about getting kicked out of your apartment, or not having enough food. I remember my father, he grew up in a family that was poor, and he said as a kid that his mother would wake him up at like 3 in the morning and they would have to move. So he couldn't figure out why everybody moved at 3 in the morning. And it was because they couldn't pay the rent. So that's my dad. Other risk factors, and again, I'm going to say that we could do lots of courses on discrimination. And Diana Padilla is one of my colleagues here, does a lot of work, by the way, on cultural competence, the lack of social support, history of psychiatric illness, housing instability, substance use. So these are, again, are some of the risk factors that would cause somebody well, in some cases, it may increase their exposure to trauma, but would not help in terms of healing. Yeah, I'm just reading. Okay, let's see. The pandemic is crippling. Our protective factors hardcore. Yeah, you know what? You have to really look at, what you're going to do. I was thinking about this when I remember when it started. I remember thinking, how can we not go to work for a long time? Like that's going to be crazy. And you thought, oh, it's going to last 2 weeks and I'll be back at the job. And then after a while, when you figured out that it wasn't going to be so quick, I think people have had to figure out for themselves, how do you look at what are the things that made you feel good, and what do you do with them? So for example, some of you used to go to the gym all the time and now you can't go to the gym. Now, some of you can figure out ways to work out. Some of you went to church regularly, and depending on your church, it may be back or may not. And that varies according to, I don't know, I think the states, but also some of the religions. So you've probably had experience in your own resiliency factors, or maybe lack of them. And yeah, I'm just reading what Barbara wrote. I believe many people allow themselves to feel isolated at home. Home is where comfort is, and now home is safety and support. Also, it's where you do not have to wear the mask. We all complain about the mask of having to wear. So I think home has changed for people. And again, you all may be in very different and difficult situations. So if some of you have small, like in New York, people have small apartments. You may have a couple of people in the apartment. You can't get out. Yes, cabin fever. So I think it's just been a challenge. And it's something I think we just have to kind of you have to work out for where you are. And actually, yeah, as Doug was saying, home is really the only place I feel safe. Yes, and You know what else? But taking it back to our clients, some of our clients are in homes where there's domestic violence or abuse. So it's for them, it may not be safe. But it's, I'm always grateful that, and there's a lot of gratitude in actually having a home. For me, I have an apartment. I really love it. And I feel very grateful. Yeah, for people in shelters, that's been a big challenge. And I don't know what's going on with that. Yeah, and for those of you, you're dealing with young people who wanted to go to graduation, go to the prom, they are struggling as well. So, yes, there's a lot that goes on. All right, so I'm going to take it back to, I already went over that. Some of you are familiar. Oh, somebody said, Michael, you've been doing in-person therapy. I'm not sure how long that will last. That is interesting. We will give you the link later on about other trainers. Okay, so other trainings. So let me take it back to the ACE study. Whenever you study courses on trauma, by the way, they talk a lot about the ACE study. And ACE stands for Adverse Childhood Experiences. And there were 2 doctors who worked on this, and they worked on it in 1995. So you're saying, like, why are we doing this old thing? But 2 doctors, Dr. Anda and Dr. Felitti, one was at Kaiser Permanente, the other one was at the CDC. And in the 1980s, they had worked with people who were morbidly obese. And they had 2 sisters, and both the sisters had lost like 80 pounds each. So they, said to themselves, oh, this is a success, that we did really good work. And then about 6 months later, guess what? The sisters had both gained back all the weight plus more. And so they were trying to figure out, was it genetic because they were sisters? Was it cultural because they were Latina? And what they found out was what both sisters had in common was they were both being sexually abused by their father. So their gaining of the weight was their way to protect themselves. Unfortunately, it didn't always work, but that's real common where sometimes people figure out how do they protect themselves. You can sometimes see that after sexual assault. But anyway, so they figured, why don't we start to ask these questions early? Because if we looked at what went on before somebody was 18, we could actually make interventions earlier then. And so what they did was they, and I will say that the SUNY Buffalo State University at Buffalo, their social work school has been doing work on trauma-informed care. In fact, the whole city is trauma-informed. And what they did was they broke it down into abuse, neglect, household dysfunction. So the first 2, abuse, had to do with what the child experienced. So was there physical abuse? Was there emotional abuse? Was there sexual abuse? The second one goes with neglect. So sometimes people forget neglect, but sometimes people not having enough food or parents disappearing for a while, or emotional neglect, so parents not being there. The household dysfunction really dealt with what else was going on in the home. So was there mental illness? Was one of their relatives incarcerated? Was there violence toward the mother? Was there substance abuse? Was there divorce? And actually, they've done this all over the world. And some countries had more shame around divorce than, say, maybe the United States. So they looked at, and there were like 10 questions. And then I don't do this in a training. I think I did this once before, an in-person training. I had people figure out their ACE scores, and then it really kind of shut down the training because you all may have high ACE scores too. But for me, the higher the ACE score, the more the correlation with some of the illnesses that we see later on, which I'll go over. In addition, the Finkelhor and did some of their studies, and they looked at, for example, lower socioeconomic status, peer victimization, peer isolation, exposure to community violence. And sometimes when I've shared this in a training, people say, well, that's the way my neighborhood is. That's what we get used to. But we don't want to, by the way, minimize what somebody has gone through just because everybody's going through it. All right, I'm just looking. Yeah, and actually, that's why, Michael, the ACE study was a good start. It did not include racial violence or poverty. And that's why, actually, when they added the ACEs that you can see on the slide, you can take into account some of the things that you just mentioned. There's actually, you know what, there's a lot of good TED Talks, by the way, on the ACE study. And there's a doctor in San Francisco, and unfortunately, I couldn't find her name this morning, but she really talks a lot about it, and she looks at it a lot, again, from areas where there's poverty, and talks more about people of color. So go to TED Talks, and the good thing about TED Talks is they're 20 minutes, they're easy to access. So I think it's important to kind of look at. What they found, by the way, was that there was a correlation between, now they didn't say it caused it, although some of the TED Talks have said that it caused it, but this is what they find, is that for some people with physical health, they might have heart disease, COPD, which is lung disease, diabetes, mental health, depression, suicide attempts, behaviorally substance use. And these are a lot of, oh yeah, Dr. Burke, thank you again for writing that in, Karen. Yes, go to the TED Talk and get Dr. Burke's presentation, because she is really good. And actually, she believes, by the way, that it's not just correlation, that it's cause. And so I think it's something to look at as well. Yeah, thanks, Jordan. Personality disorder is pretty big for people who have experienced trauma. Yes. Oh, yeah, she's the California Surgeon General. She's really wonderful to listen to. So I think it's important to kind of look at that. Anyway, the key, yes, people are writing in. Yeah, you know what? There've just been so many traumas, as the person just wrote in. So it kind of almost doesn't end. It's interesting too, because we're dealing with COVID, and then some people are dealing with other kinds of traumas personally, and then what's going on in terms of the climate. So lots to do. So let me segue too. So that beginning part was really, and again, I think I was telling somebody recently, this is like an appetizer course. So we start to talk about trauma. Could we talk more about it? And I know some of you, by the way, are experts in trauma, and it'd be important to go to other courses as well. But what is trauma-informed care? Because that term is thrown around a lot. And what does that mean? So a couple of things before I even go over the bullets, but it kind of changes the question. And this comes from, you know, there's a Center for Trauma-Informed Care that actually has a lot of information that's helpful, but it really changes the question from what's your problem? You know, sometimes we say to people, what's your problem? Or what brought you here today? But we say it in a voice like, what's your problem? You might not say that, but to tell me what happened, and actually then believing people, because when we believe people, that actually when somebody tells you a trauma and you don't believe them, then that is another example of like a double trauma. But so you want to believe people. And the two keys, by the way, for trauma-informed care is, one, how do we create safety for people? And how do we avoid re-traumatizing? So it's a systems approach. If some of you have had agencies where you've looked at all your systems, and it could be everything from the physical space, you know, if you have a place that's hard to get to, or your office is in a, let's say your office is in a basement and it's really dark and scary to get to. Yeah, I'm just reading. You know what? I'm going to say that the ACE study is something as a beginning. There's a lot that it didn't include, and I think in the future, we'll see more information on that. So going back to this, and we want to, again, avoid re-traumatization. So how do we create safety, and how do we not re-traumatize people? And how do we how do we understand and reflect on our practice to avoid re-traumatizing? And Using universal precautions means just assume that everybody who has come to see you has experienced trauma. So here's my thing on safety, and I think creating safety is an important piece. And I know from some of you who I know you're good at it. So here's a question or something to think about. You really can't create safety for others if you don't feel it yourself. So everything your clients are feeling, you may be feeling as well. And I thought of this or kind of redid this in terms of COVID because of some people who were going back to work were really scared to be going back to their jobs. People I know who were going to teach were scared. And it's important to kind of look at that as well. So you have to really figure out how do you create safety. Hold on to the re-traumatizing because we'll start to look at that. Actually, I will throw out one question before we get to re-traumatization is, what do you do to create safety? So if a few of you would write in, what do you do to create safety for people? So people would please write in. Being calm, yes, I think that's very helpful these days. Thanks, Desiree. What else? Acceptance. Yes, thank you. Letting them know it's confidential. Absolutely. To listen, show empathy, be patient, be open, not to judge. Again, some of the commonalities of calm voicing. So voice is important. Following their lead, letting them know that you're there for them, pacing, tone, authenticity, empathic, patience. Okay, they're going up pretty quickly. Let's see what I can see. Offering reassurance and compassion, patience, assuring them they are safe or can receive help, letting them know. Yeah, so there's commonalities around, I'm going to say body language, voice tone, and also active listening and really listening to people. And as many of you have written in, judgment-free zones. So there's a lot I think you can do. And actually, thanks, Oscar, for saying wearing a mask and ensuring, because one of the things that happens too is you used to be able to, just walk into your sites, by the way. Sometimes you need to let people know what that means. Or if some of you are doing therapy and you're wearing a mask and they're wearing a mask and you're 6 feet away, you have to figure out for yourself, how do you create safety? Yeah, safety plans are important. Yes, and actually, as Leslie wrote, not making the client repeat the story over and over. And that kind of goes to re-traumatization. Also to be culturally competent, which is a fancy term these days, but also to kind of look at what do you do to create safety, or to assume that sometimes people have experienced trauma as a result of their race or ethnicity, and just to value that. Yeah, the masks and the sanitizing. So there's a whole kind of gamut of things. The key is you can't really create safety for people if you don't have it yourself. So do your best. It sounds like many of you have already kind of thought about that. So some people had asked about re-traumatization, and so I'll give you out a few because sometimes here's some examples. In upstate New York, in a city, the security guards at one hospital changed their uniforms to the same uniforms as the policemen in that city. And so a lot of our clients were kind of afraid to go into the agency because of that. Sometimes, and this too, is you look at, when somebody has a loud voice, you can see this, for example, you could be in a waiting room and lots of people are in a waiting room, and then somebody starts talking loudly or starts fighting. Then a lot of the people who are in that waiting room can be traumatized. Although now I guess the waiting rooms are not as crowded as they used to be, but that is something that happens. So sometimes loud voices. And again, when you keep asking people to repeat their story. The thing with trauma, by the way, is sometimes people want to know all the details. And for those of you who are trauma-specific counselors, you know that you don't have to do that. In fact, by asking, it can re-traumatize the person. Yeah, and actually, Leslie, ask the client what helps them feel safe. So I think that's an important piece. And cultural humility, which I think Paul's doing a training tomorrow, Paul Warren, one of my colleagues, on cultural humility. And I think that is an important piece. And actually, just to be humble and to accept where people are. I think if somebody was asking about a list, I think that if you Google at SUNY Buffalo, I think they had a whole list of how we re-traumatize people. So yeah, so PTSD re-traumatizes. Yeah, so again, as you ask people to keep telling the story over and over again, that can re-traumatize people. So you don't want to do that. Some things you're going to have control over and some things you won't. So for example, if you are a big man and you have a loud voice, you may almost traumatize people without you thinking it, and you don't have control over that. I think there was an agency in Binghamton that was a women's program, and they hired a man who was pretty large. And at first, a lot of the women were afraid of him. But what they did was they gave him training on trauma-informed care. They had him co-lead groups with a person who the women trusted, and then they developed a trust with that. So it's important to look at that. Yeah, sometimes the client wants to share their trauma story again and again. That's a whole nother, I think, a training thing as well. Yeah, we're going to get, by the way, into what works for trauma. So hold on to that. All right, so what are some of the principles? And I've got actually slides on each of them. So these are the principles from SAMHSA, and here they are: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment and choice, and cultural responsiveness. So let's break it down by. And again, actually, this comes from Portland State University, did a lot of work on trauma-informed care. It's actually the state of Oregon seems to do a lot. And what they did was they broke it down into what the staff can do and what clients can do. So you'll see some of them are the same. So for staff, making sure the staff feel protected. And so for those of you who are supervisors, you know that that's a challenge as well today. Clients, you do the same. For staff, communicating clear efforts, same thing. And again, with the whole retelling of the story, you want to eliminate any shame around that, because the person may already have experienced a lot of shame that they're bringing in, and you don't want to create more. Ask for feedback and just acknowledge the fears. All right. So another one is trustworthiness and transparency. So, it's just being clear and direct, communicating with people. It's funny, transparency is a word that's been used a lot by the government, and it's like some people are, some people aren't, but again, I'm not going there. But if there's new policies, like for example, some agencies were letting clients know that as they opened up, that when they came to the agency, they would get their temperature taken, that they would be expected to wear a mask. Some places would provide masks. So just letting people know what that meant. So it can be scary. It can be scary, but again, information is power on that one. Another one is peer support. And, when you think, for example, about some of the counselors who I've been working with in New York, they are working with their clients who are working at home and educating their kids at home. And so they try to figure out, like, what's the best way for people to communicate? When's the best time? One of my sisters who teaches in Chicago at actually the high school that Michelle Obama went to, what she said she was trying to do was to make videos of the lessons so that the students could look at them at any time, because in some cases there might have been one computer at home, the parent might have been having to use it, and she so wanted to make it accessible to everybody. So also, you know, again, I know that some people, I mean, some of the challenges, and you know this better than I, about teaching, and some of you have had to learn this as well, right? About how to counsel virtually. You know, what do you do if somebody doesn't have access to that? How do you keep confidentiality on that? So I think those are some of the things that many people are working with. And kind of reminds me of a good friend of mine who's a therapist was saying she was FaceTiming, or she must have been doing Zoom with a client, and she said, you know, she knows in person, she knows how to be empathetic, she knows how to be warm, she knows how to do all those things. And she said when she first started doing it, she would be trying to empathize with the client, but at the same time she could see her face, and then she'd wonder, like, did she wear enough makeup? Should she have combed her hair differently? So people have gotten used to it, but I think it was a challenge. I think it's a challenge too, is you're good at one way and then all of a sudden you have to do it a whole nother way. So that may take away from some of your safety, but again, with practice, a lot of people have been doing it really well. Other things around collaboration and mutuality. So sometimes now people are working with the public health system, and sometimes you have to teach people how to work with some of the different systems. It's funny, in my notes, by the way, I had something, I don't know if people are familiar with Stephanie Covington, but she's done a lot of work on gender response treatment. And she, I would say Google her and go to her website, in that she really looks at how to work not just with men in treatment, but actually with people in treatment. But she does a lot of work on women in treatment and how that might be different for men. Empowerment and choice. Many of our clients have not been given choices. Many of our clients have not had a voice. You know, for example, if somebody's a victim of domestic violence, they might not have, they're not used to, or they may be afraid to state some things of what they feel. So I think some of the healing comes from providing choices, having the clients, by the way, choose their treatments, and encouraging them to speak up. And then finally, in terms of principles, but again, as people have mentioned, you could do a whole training on this, but I think it's really important to look at in terms of cultural responsiveness. And one of the things too is, you know, how do we recognize cultural strengths? How do we build on that? How do we deal with some of the healing rituals within a culture? I don't know, I was just thinking, for example, from what I've seen on television, around some of the native tribes and how they've been using a lot of healing rituals. I was also thinking, my late husband was Dominican, and what he used to say, by the way, is one of the strengths was that when somebody was going through something, everybody in the family really got together to really support the person. And you know, I thought of that today. And then he always used to say, if you hear merengue, it will make you happy. So I've been listening to merengue and salsa a lot and going to Zumba class during this, and it is saving me. So I don't know if anybody in New York is doing the same thing or all over, but it's looking at, you know, what are some of the rituals that people have, and do no harm. So what do your policies? So for clients, do your policies do harm? How do you work with clients around this? And again, and people have mentioned this, to be mindful of historical context. So, you know, for example, when somebody comes to see you, and they may have one traumatic experience, but you know that it's not going to be the first. So you want to be patient and understanding around that. I don't know if people want to add anything about that before I do some piece on trauma in the body. I would say take more courses, but that's easy for me to say because I'm a trainer, but really to look at what kind of strengths do people bring? What have people gone through that really showed they had a lot of strength? And really to build on that. So just a little bit about trauma in the body. A couple of things to keep in mind is that you can tell sometimes when someone has gone through trauma, they might always be on high alert. And actually in the days when you could go up to somebody and like touch them, which can't do that anymore. But you ever do this where you went up to somebody and sometimes you surprised somebody and they jumped? So that sometimes people have what's called an overstimulated amygdala. The amygdala, by the way, is that part, it's in the limbic system. It's that part that helps you with survival. So it's about kind of that fight, flight, or freeze. And you want to have it because it gets you out of dangerous situations. But the problem is for some people, once the trauma is over, they still have that, they're still on high alert. One of the things also, and this is also in the limbic system, is it's called the hippocampus. And one of the reasons you want to have your hippocampus working is because it gives it context. And they work together. So for example, if you're in the training right now, and let's say I hear like a truck outside that makes a lot of noise, sometimes I know if people have been in, let's say they've been in Iraq or Afghanistan and they hear a loud noise, they may think that they're back in Iraq or Afghanistan, and they're like kind of get into position. And one of the things that happens is when the amygdala and hippocampus work together, it'll give it context. But sometimes what happens is for some people, they become less effective in making connections. And that's why, actually, as somebody was talking about, there's a variety of different interventions that work with that. But it's just important to kind of look at that. Just to kind of go into that fight, flight, or freeze. Sometimes it's interesting because sometimes after somebody has experienced a trauma, they can't talk because the part of the brain that deals with speech is kind of like turned off. And what do we expect people to do? We expect people to talk and tell us the story. So be aware of that. And those pieces on the bottom, a real common thing for people is if they've been sexually abused, that sometimes what happened is they can't recall the abuse, but as they get better, they may have memories. So I used to see that a lot after a couple of years in recovery from alcohol and other drugs. And so you want to have your antenna up about that because it caused a lot of people to relapse. Now, just a couple of things about what's the difference between trauma-informed and trauma-specific. So any organization can be trauma-informed, by the way. So it values the principles and that we kind of went through. And, I'll give you an example. I was talking to a friend of mine who used to teach yoga, and she said, like, what are you doing? What are you teaching on this trauma-informed care? What does that mean? So when I was telling her what it meant, she said, oh yeah, when we had a training and for yoga, we were instructed or suggested that if we were going to touch somebody, that we asked them if it was okay. It's kind of like, remember we used to sometimes teach that if you were going to hug somebody that you asked them for permission. And so what that means is that any organization can be trauma informed, one that creates safety for people and avoids re-traumatization. Now, other things to keep in mind is that there are very trauma-specific practices that work. You know how we always look for evidence-based practices, like what does the research said? And that somebody I think Michael was talking about some of these, but here's some that have been used. I don't know if people are familiar with EMDR, eye movement desensitization and reprocessing. It's actually was used a lot in New York after 9/11. And what it had to do with was people moving their eyes back and forth and retelling the story. And when a person was trained on how to do it, that it started to integrate those experiences. I'm making it sound simpler than it is. My thing with EMDR, by the way, is that people need to go to somebody who knows what they're doing, because sometimes they can have a 2-week training program somewhere, and one of the challenges is when you start to bring up, let's say, one trauma, like say for example somebody just wanted to deal with the trauma of 9/11, and then all of a sudden they start doing the exercises, and then all of a sudden every trauma that they've had manifests. So that is something to keep in mind. Other things, CBT, cognitive behavioral therapy, works well. Seeking Safety, which was made by a woman named Lisa Najevitz, they were working a lot with women who had experienced domestic violence and post-traumatic stress disorder and substance use. And that is a good one. I've heard that they've just redone it, and they are targeting LGBT people. So I think kind of keep your eye on that as well. And then, as somebody mentioned before, around prolonged exposure, I'm going to say one of the good things that the VA has done kind of in response to Iraq and Afghanistan is they've done more, I guess, interventions around treatment for people who've experienced explosions and things like that. And so sometimes prolonged exposure is another one that's used. My key with that one, by the way, is you want to make sure that people know what they're doing, because it can be really dangerous if you don't know what you're doing. I remember when we were at NDRI, National Development Research Institute, we were doing a lot of trainings for the Veterans Drug Court, and Judge Russell, who's up in Buffalo, and I think he's still there, so he said, "Mary, I hope in the training, you're not going to show movies with all kinds of explosions or anything." We said, no, we're not going to do that. But it speaks to, again, of these are things that work, and it's really helpful for people to get them. And if people want to add in information about that, they can. One of the things I think is important is to stay in your lane. And what do we mean by that? If you're not a trauma-specific person, don't pretend to be one. I think one of the good things for many of you who are good at creating safety is people will tell you a lot of information. And so sometimes they'll be telling you things that you really are not equipped to deal with. So you just want to, for example, validate the person's experience, but it's important really to have resources and make referrals for that. Yeah, and does that make sense? So you can agree or disagree, but I think people sometimes get into trouble when you kind of go over your head about what you can do and what you can't. Okay, so one of the last pieces that we do for this course is on vicarious trauma. And this is something that we have to look at. And basically, it's really you hearing or witnessing other people's traumas and suffering. And that's what you do. Many of you are listening day after day to other people's traumas. And it doesn't mean that you have to have experienced the trauma, but the fact that you're listening. And they say it's one of the reasons people develop vicarious traumas, because they're empathetic, too empathetic. But that's what we get paid to do, right? We are taught how to be empathetic, but then the challenge, by the way, is that sometimes we can take on other people's traumas. One of the things that happens is it's a cumulative effect, so it kind of adds up, and it's something you really want to pay attention to and take care of. One of the differences, I think, between, let me see if it's on the next page, but sometimes you feel burned out because you're tired, and you take a couple of days off and you feel better, that's usually burnout. And burnout really has a lot to do with what's going on in terms of the concrete stressors. So what's the physical environment? What are your work hours? Some of you have many, many, many clients, and now you're actually struggling to find where your clients are and how they're dealing with things. But it just, with vicarious trauma, you start to get kind of it really affects the rest of your life, not just your 35 to 40 hours at the job. And if you're a supervisor, when your staff is experiencing a parallel process or they're acting a lot like the clients, you want to kind of look at that. So that is a big thing. And then another piece is, how do you take care of yourself? So, in fact, it's funny, I think we've done courses on stress management and vicarious trauma where you can start to kind of look at, what are the ways that you take care of yourself. And so this is just the ABCs. So awareness, you can't really figure out and work on something if you don't have your own sense of awareness. Balance, how do you create that? I think that's a challenge. And connection, and that connection I think has been really important. So actually I'm going to throw out a question is, what have you been doing to take care of yourself during the pandemic? What have you been doing? So please write in, what are some of the things that you are doing? Anybody? If you would write in, please. What have you been doing to take care of yourself during the pandemic? Actually, I'm hoping people are still on if I'm missing anybody. So what are some of the things that you've been doing for self-care during the pandemic? Please write in. Oh, cool. I see things. Great. Oh, a little bit of everything. Thanks. Sorry, it wasn't showing up on my chat, and now I see it. Got it. So everybody's been doing, you can see as people are, oh, thank you. Sorry, I'm going backwards just to see what people are doing. I'm going to stop there. So the world appears in crisis. Yes. Eat, yoga, more exercise, scream at the sky, walks. Yes. Eating right, listening to music, hot baths, close friends, taking walks, cooking meals, keto meals, taking your dog for a walk. So, a lot of people who have pets have found that to be really helpful. Reading, scrapbooking, prayer and gratitude. Yep. Television. Yeah, working at home can be helpful. Yeah, so it seems like actually this is pretty cool, by the way, because people seem to be doing knitting. It's interesting because knitting increases serotonin and dopamine, by the way. We know, for example, like exercise increases endorphins, but there's other kinds of things. Staying connected virtually, acting class. Yeah, there's a lot of things people can do online. Breathing, praying, YouTube videos, unplugging from social media, biking, spending time with people in the house. Yeah, a lot of people who have other people they're living with are getting to re-know them or to know them again. And some of you are trying to hide from them probably, but oh yeah, spending time with your mother, baths, emotional press. Yeah, thanks everybody. This is really helpful. So you can see this may give you ideas for what else you can do. I think the key, by the way, is that you do them all of the time. Not all the time, but that you really incorporate them into your life. So, sometimes with work that we obviously have to spend time at work. Although I have to say, I really still love my job, and I think that's really good, and it's kept me. It's been really helpful to have a job during the pandemic. But after this, I will probably go for a walk. Right? I did go this morning. Yeah, religion, Netflix, and chill, binge watching TV, gardening. Yeah, so I think actually this is pretty cool, making your home a more pleasant place. So the key is, again, that people have written in many, many things, and I appreciate that. All right. So let me get to the end of the chat. Yeah, church services via computer. It's interesting how some churches have opened and some have not. And some of that has to do with safety. So the key is always to kind of take care of yourself. You know what? I always sometimes go through some of these slides really fast because I think I'm gonna run out of time. So before we get to filling out the evaluations, you know that I'm gonna have to start to change this at some point, but this is like one of my favorite pictures to have at the end of a webinar, because hope is something that you provide for people. And my hope is that this was helpful and you got to learn something more about trauma and trauma-informed care and maybe how you could use it for yourselves. So before I get to the last slide, what questions do people have? What questions can I answer? Oh yeah, it's a calming picture. Yes, I think so too. Yeah, meditation is really good. Yeah, lots of people are doing their 12-step meetings online. Although it's interesting, near where I live in Mamaroneck, and a lot of the AA meetings are now in person, but you have to sit 6 feet away from each other, and you have to also clean the bathroom before you leave, and spray everything and desanitize. So I think that is pretty cool.